Good evening, everybody. On behalf of Dr. Hema Divakar and Team Artists, I extend a warm welcome to all of you to this Knowledge Cafe. In today's webinar, we deal with a unique topic, enhancing high-risk pregnancy management and the role of magnesium, vitamin D, and more. So today we have a keynote address by Professor Narendra Malhotra, who will delve in depth with this topic. And this will be followed by a panel discussion. The panel will be moderated by Dr. Hema, and we have esteemed panelists from different parts of the country who will be giving their valuable inputs on this topic. So we begin the session today with the keynote address, and I hand it over to Dr. Hema to introduce Professor Malhotra to us. Over to you, Dr. Hema.
Thank you, Dr. Rita. On behalf of artists and Pharmed, we have specifically titled the topic as Magnesium, Vitamin D, and more. Because whenever we speak about Dr. Narendra Malhotra, it's always something more. And that has to symbolize in the theme and the topic today. Of course, what is displayed on the slide here, we could have had another 40 slides in continuum telling a lot many more things that he has done. But what is not displayed here, according to me, is so much more important in the personality of the esteemed speaker, Dr. Narendra Malhotra, whom we very, very proudly present to you. His organization, Smriti, which thinks beyond the usual technical and scientific aspects, it, in a wholesome way, engulfs the social and the cultural, economic determinants, and the slogan of Beti Bachao, Beti Padhao emerged from the heart of Dr. Narendra Malhotra well before the government took this theme ahead many, many years later. He's a managing director of the Global Rainbow Healthcare, which is now the Ujala Cygnus Rainbow Hospital, director of ART Rainbow IVF, the past president of Foxy, but an evergreen president, if I may say, and as I said, director of the Foxy Smriti Manyata Center for Skill Enhancement. He is, needless to say, a much sought after speaker, and the special quality of Dr. Narendra Malhotra is however busy, however engulfed, and people are pulling him from all sides, but he will always, with a smile, say, yes, I will be there for you. And that's how we have sourced him, despite his very compelling schedules, because Narendra's reach, especially in the CEFOG region, who has made a mark consistently and persistently to try and reform the South Asian region as if it were. So its contribution is beyond the boundaries. Many, many orations, many publications. Here he's just mentioned some hundreds of keynote addresses. 356th keynote address was just delivered. This is 357. So a whole year round, just 365 days in a year and 24 hours in a day is not enough for Dr. Narendra Malhotra. So we present to you Dr. Malhotra, who will speak about specifically the role of magnesium in enhancing the outcome in high-risk pregnancy. And keep your questions ready, because if the guest can stay over for a couple of more minutes, we will indulge the answers within the panel. And if he can't, we will take quick one or two questions before Dr. Narendra leaves the webinar, because as I said, his schedules are rolling one into another. Oftentimes I've seen him with 3 computers, with the channels changing from one to another, and you are so very special to us, Narendra. So over to you for the deliberation of the topic for the day, enhancing and optimizing the high-risk pregnancy outcome, the role of magnesium.
Thank you, Dr. Hema Divakar. Today, the commitment is different on the other side, because it's Keshav and Sanjika's first wedding anniversary tomorrow morning. So they're all calling me there. I said, okay, 10 minutes.
Wish and bless the couple on our behalf too.
Thank you. Thank you. So, without wasting any more time, let's go ahead straight to the topic which has been given to me to speak on. I've been working a lot on this with Pharmed on a lot of work, clinical work and research. And because the add more was added, so we'll add a little bit more to what only magnesium and vitamin D. We all know that they are both important. Now, firstly, let's define what your high-risk pregnancy is. Now, it is a pregnancy which needs more care. It is a pregnancy where the monitoring, where the fetus, mother, both are at increased risk of something wrong going on. And this risk may be because of the pre-existing disease or pregnancy. So we need to optimize. Now, if we briefly see, these risks are going to be in the form of first trimester, second and third, first, second, third month, abortions, recurrent, congenital anomalies, 4, 5, 6 month growth retardation, intrauterine death, fetal abruption, 7, 8, 9, preeclampsia, and preterm labor. Now, these are what we call as the great obstetrical syndrome. And what is responsible is the maternal age, pregnancy-related factors like multiple placental problems, fetal-related factors like anomalies, RH, fetal growth abnormalities, and mother's age of 65. And the other potential risk which the mother will face is hemorrhage, infection, organ failure. Fetal risk will be of preterm, small babies, and developmental delays. So how do we approach this pregnancy? A multidisciplinary team, which will include you, a maternal specialist, a specialist dietitian, a nutritionist rather, and a pediatrician, and intensive prenatal care. So this high-risk pregnancy needs more attention because why it is happening is because there are the challenges because of increased metabolic demands, common deficiencies of magnesium, vitamin D, iron, and folate, and these deficiencies leading to problems. So let's see what can we do. So let's see what the woman requires in pregnancy. You see, she requires a lot of protein, a lot of carbohydrates, and all these vitamins which are very important. A, niacin, zinc, magnesium, folate, calcium, and vitamin D. And when we look at this chart, or research factor, the number of pregnant women with these values and the number of Indian women with these values. So all Indian women, almost 60 to 70% are deficient in everything. Energy, protein, DHA, vitamin, magnesium, folate, iron, vitamin D. And this undernutrition, the fetal undernutrition and what we call as the fetal origin of adulthood diseases will start in this baby. And this baby is later going to deliver with hyperlipidemia, hypertension, central obesity, insulin resistance when this baby grows up to the age of teenage or 20s or 30s. So the adult diseases have started here because the mother was deficient of all the nutrients. And the conceptual framework of how this maternal diet and micronutrient will affect is, see, all these will affect all the metabolic syndrome. Epigenetic gene is downregulated by folate, increased stress hormones, restricted blood goes to the baby, cardiovascular function suffers, renal function suffers, pancreas suffers, body composition suffers, and later on this young newborn in older age, adulthood, will develop hypertension, cardiometabolic disease, and see. So let's come to what we can do. First is you need to give calcium. So we need to give calcium because a fetus will take about 30 grams of calcium by term, and 80% of this is during the third trimester. So calcium supplementation after first trimester would there. In when the mother is lactating, she will lose another 400 milligram. So the dose has to be increased, and the calcium loss may be greater if there are twins, as high as 1000 milligram. So your calcium proper supplementation is needed. What about vitamin D? Is responsible for bone health, immune modulation, anti-inflammatory properties to the mother, to the baby, both. Pregnancy specific benefits is it will prevent gestational diabetes, preeclampsia, low birth weight, and deficiency will be overcome by supplementation and safe sun exposure. Now, this sun exposure is not in saris. So that is, you have to be careful. And it is the sunlight between 11 a.m. to 2 p.m., which gives the vitamin D. And then you have to lie without clothes, totally exposed in the sun, maybe on your terrace, maybe on the beach. Of course, you cannot walk without clothes on the streets. That is, and those who are with a darker skin will have a lesser vitamin D developing from the sun. Hence, the dose has to be given to them as supplement, 600 to 1000. And when we look at the figures and the research by the American Clinical Nutrition, the Archives of Disease in Children, 42% North Indian women are deficient of vitamin D. And it's not only India, it's in UK, UAE, New Zealand, Netherlands, where there is less sun or where there are women wearing robes, that would be the women there. The third is, or the most important probably is, which we neglect, is magnesium. Now we know that magnesium will relax your muscles, the nerve function, blood pressure regulation, and during pregnancy it is said to prevent preeclampsia, eclampsia, and manage preterm labor. That's how we give magnesium itself. And the recommended intake would be about 400 milligrams. Now there is going to be a different figure by various studies, but let's cut it down to about 400 milligrams a day. The others which was given to me is the iron, the calcium which we talked about, omega-3 fatty acid, very important. A small island in Norway, they had no preterm deliveries because it was a 100% fish eating island. So, but now we have omega-3 or DHA from algae. So even vegetarians to be supplemented. So every pregnancy after 12 weeks of gestation, omega-3 should be added. Why all this is important? Because the importance of the first 1,000 days. Conceiving 270 days of pregnancy, that is pregnancy last trimester, then 365 days of breastfeeding, and then the second year of the baby. So the baby requires complete nutrition from the mother on. So maternal nutrition becomes very, very important to supply the baby. And this nutrition requires, as you can see here, from the food, all this food should be eaten by this pregnant woman to give them adequate amount of vitamin K, D, E, C, B12, B9, B7, B6, B5, B3, B2, B1, and A. So A, B, C, D, E, F, all that, we went the other way. Let's concentrate a little bit more on magnesium. Now, the magnesium in the body is mainly intracellular, 19% in the soft tissue, and only 1% in the plasma. So when you're doing a plasma magnesium, the 1% does not tell you whether the deficiency is there. So with normal levels also, she may be deficient, or with deficient level, she could be probably normal. And what does this do is, if the daily intake is poor, the deficiency will manifest in the intestine, in the kidney function, in the muscle function, in the bone function, and the whole body starts suffering. So you see the magnesium deficiency right from head to toe. Now, head to toe in a normal person, and also in when pregnancy is there, of course, the deficiency is going to be much more. So hypomagnesemia, that is in blood, and magnesium deficiency are often wrongly used and interchangeable. See, the patient may be hypomagnesium, that means less in serum, but she could have the correct stores. So she's not actually magnesium deficient. So that has to be kept in mind, because doing test is not going to give you the right value. So subclinical magnesium effect, even when the magnesium levels in blood are normal. So that is the other. So concomitant level about 0.7 to 0.85 millimoles, interchangeable with the plasma through the renal excretion and bone reabsorption. And in order to maintain the plasma magnesium with the reference value, these patients will have magnesium decompartmentalization. So from the muscles, from the bones, it's from the tissue, intracellular, it will come into there. And the bones will get depleted, and the muscle cramps and bone pains and all that starts. So why this is important is because we cannot ascertain deficiency by magnesium measurement only, because only 1% is in the blood. You need to assess them in some other way, which we'll just tell you. And there is no definitive clinical universal measurement method available right now. And if there is a long-term deficiency of dietary magnesium, that will lead to decompartmentalization and will lead to the clinical signs and symptoms. So how do we assess? The test is serum magnesium, 24 hours excretion in urine, magnesium loading test, but magnesium concentrated in RBC, which is commercially available, is probably the best test available and can give us early indication of magnesium deficiency, intracellular. Isotopic analysis, ionized magnesium are the other tests which are there. So available commercially is the red cell magnesium, which is a better assessment tool, highly sensitive. Red cell is commonly used because it is the intracellular, and such a range would differ in various things. So you still, the standard ranges are not there. So we still can't say this is the gold standard of it. What happens in pregnancy is practically the levels remain the same. As you can see, a non-pregnant adult, the first trimester, the second trimester, and the third trimester, and all the three values, because sometimes you'll get it in milligram per deciliter, sometimes you'll get it in milli equivalent per liter, and sometimes you get the reading in nanomoles per liter. So there's no standardization by the lab. It's also, you report it in one single way. Now, low magnesium in pregnancy is seen in low-income women, which have a food deficient. The responsive gene, the TRPM3 regulating intestinal renal uptake is at fault. And there is an inverse relationship between this gene and the urinary magnesium at 37 weeks, which will tell us that the late onset of PIH would be there. So at 37, 38 weeks, women having higher magnesium excretion will significantly have a higher systolic and diastolic BP. So that could be one of the screening tests for late PIH. Now, this deficiency will be associated with many other problems. PIH, eclampsia is there, fetal growth retardation, fetal growth problems, gestational diabetes, preeclampsia, and preterm labor. Now, when we look at these studies, they show that up to 42% of women and men could be deficient. And it is more in women. And the proportions are higher in postmenopausal women and those with diabetes. And so about 400 to 440 milligram of magnesium in India is recommended in lactations in pregnancy, 370 in normal. So even normal people like us, you and me, should be taking some magnesium to keep our muscles and bones or the diet, which we'll just tell you. Now, why this is happening is because we're eating a lot of ultra-processed foods, because the soil is content. And I was with Sadhguru on the Save the Soil campaign, and Save the Soil campaign to re-enrich our soil by the minerals. We are depleting our soil of that. So Save Soil campaign by Sadhguru is very, very important aspect, which will affect the health of the future generation. Then the dietary calcium magnesium ratio. If you take excess of calcium, the calcium magnesium ratio will reduce the magnesium absorption. And of course, OCPs and magnesium supplementation would be the only way. So if we give, yes, the question is there, if we give too much of calcium, then the magnesium would be propped. So you'll have to probably increase the magnesium or give magnesium with the calcium and with vitamin D3. So subclinical deficiency will occur with vitamin D deficiency. So calcium, vitamin D, magnesium, all these three are going to come together and have to be tackled. So for a routine OBGYN, we need to be very, very aware of these three and of course the others also, and be careful on supplementing this. So when we look at the internal medicine books, pregnancy lactation, rapid bone formation in fetus, vitamin D deficiency, treatment of vitamin D deficiency will improve the magnesium, reduced intake on the face of increased urinary loss during pregnancy, and all these would be there. So accelerated bone. So that's what we have to be careful. So magnesium in studies has demonstrated a superiority over placebos and other anti-epileptics to prevent preeclampsia. So that has been documented by latest studies as latest in last 1 year or 2 years. And there are a huge amount of RCTs from 2070s, which I've circled. I'm not going to go into the details. I'm just going to say that if you give the correct dose of magnesium, calcium, vitamin D, and the others, all these problems in the mothers are going to be reduced. So magnesium will reduce fetal growth retardation, increase birth weight, and reduces the incidence of eclampsia by 50% as a small thing. Also, it will help in preterm labor and preterm birth because uterine muscle relaxing. And there's again a lot of evidence on this, and a lot of case control studies have been done on this. So hypertensive disorders, pregnancy management, magnesium supplementation, essential. Prophylactic, then everybody say, why should we give prophylactic supplementation? Yes. Again, all these studies, as you see here, mainly a lot of them on oral magnesium supplementation for prevention, a randomized meta-analysis and randomized control studies have said prophylactic magnesium should be added to your multivitamins which you are giving. Also, it will prevent GDM. Now, that is very, very good. Another additional benefit which we have of hyperinsulinemia, glycemic status, and inflammation. So it will control the inflammation, and when you give calcium, vitamin D, and magnesium, GDM incidence is going to reduce how it does it? Causes impaired glucose tolerance, it will correct that. Again, a lot of studies to support all this evidence. Let's come to vitamin D and a little bit more. Vitamin D, Indians suffer. 76.9% Indian are vitamin D deficient. And you have to do the correct analysis. It's a huge topic. I'm not going into that. The role of vitamin D in normal human beings is, again, muscle, heart, calcium uptake, bones, calcitonin, diabetes, autoimmunity, and parathormone. So it's again a complete supplement for all the organs. In pregnancy, this is going to lead to, on the maternal side, to preeclampsia, gestational diabetes, preterm labor, and increased susceptibility to infections because immunity increases. In India, up to about 96% of pregnant women may have vitamin D deficiency. So again, a prophylactic universal supplementation of vitamin D3 either daily or weekly for 3 months in pregnancy should be given. In the fetus, it will cause low birth weight, neonatal hypocalcemia, and susceptibility to RDS. So there is a strong inverse relation between maternal 25 OHD levels. That's what we measure at 22 weeks. You see if it is like that. And when we look at the things, if you give 400 to 4,000 versus 4,000 dose at 18 to 20 weeks, no benefits. However, significant reduction if the 25 OHD level is more than 30 nanograms, period. So that tells us that it will prevent preeclampsia at 40 to 50 nanograms levels, and 40 nanogram level will also reduce the risk of preterm birth and will be good for the fetal development. So points to remember: 400 IU per D is less. Women with darker pigmentation require more. Approximately 20% of maternal vitamin D will be transferred to the infant via breast milk, and pregnancy and lactation will have to be supplemented by 2,000 to 4,000 every day. And these guidelines, the universal guideline is that 1,500 to 2,000 IUD in pregnancy and lactation. Only RCOG recommends a higher dose, as high as about 2,800, near to 3,000. So if we maintain the optimum level of vitamin D, there will be no problem with the mother, or less problem with the mother and the fetus. So the take-home messages for this: magnesium critical deficiencies are there. There is safety. The intolerance is not there. We give so much of magnesium when the eclampsia occurs. Nothing happens in a very high dose of 4 grams given IV straight. But it has to be given with consultation and monitoring. What are the challenges and barriers are there? That patients are not aware of this. And the compliance is not good. And there is limited access to the high quality supplements in certain reasons. And there is a variability in the diet, and that's the compliance. So our strategy should be that the clinical protocol for screening and supplementation guidelines should be there. Education awareness is very important, and monitoring is very important. The meal planning for a pregnant woman is simple like this. Everyone should plan a meal for every pregnant woman which contains adequate calories, protein, calcium, iron, vitamin A, thiamine, riboflavin, niacin, pyridoxine, ascorbic acid, folic acid, vitamin B12, magnesium, zinc, vitamin D, iodine, and omega-3 fatty acids. So this is a complete which is required. How do this? We give this, you make them a daily food plan of how much grains, how much vegetables, how much fruits, how much dairy, how much protein they should eat. And you make them a pregnancy plate. So my pregnancy plate, a chart should be given to all pregnant women, and she should be told with balance of the plate, how much of non-starchy vegetable, how much of protein, and from where this will come. That is very important. In the first trimester, we need to give extra folic acid and vitamin A and ginger for the vomiting. In the second trimester onwards, calcium and magnesium. In the third, you add vitamin C, thiamine, and a lot of water and fiber for the constipation. Supplements available are many. I mean, these are some of the few which were there in my pharmacy today, and I just took a click of them. But they are all in various sprays, tablets, syrups, and the composition and combinations are various. So we tried to look at some good combinations and see, read the ingredients, turn the box, and don't get attracted by this beautiful box. Turn the box and look at all the ingredients of what you're giving to the patient. Then decide whether she has to take it once a day or twice a day. And of course, the new food pyramid will contain everything which you've shown. The preconception intervention should start preconception, doctor visit, lifestyle, diet, keeping fit, medical conditions, then a good antenatal care and antenatal advice, regular health checkups, then the diet advice, which is very, very important for them. Then you plan their healthy meal like the food plate. Then you give the supplement nutrition depending on what you feel is deficient or where it is required for everyone. So to conclude, ladies and gentlemen, understand the importance of nutritional management in high-risk pregnancies. Emphasize on individualized care plans, future perspectives with integration of advanced diagnostic and telehealth. And one of the telehealth is our app, which is the iMums app. As you can see here, the nutrition on the date wise and what the music and Garb Sanskar and everything. And now we have the preconception on it, and we have the 2-year parenting. So we're covering the whole 1000 days because as doctors, we are spending on an average, an Indian OBGYN spends 3 minutes, average I'm saying, 3 minutes per pregnant patient. Now that is, you cannot give dietary advice. So you need a pregnancy companion, and that is where digital helps. I thank you very much. Thanks to Pharmed for asking me to share some of the views. Look at all this, start eating all healthy diets. Thank you very much, Dr. Hema.
Thank you, Narendra. I think the last bit of the time constraints and the technological catalyzation was really a wonderful thing to conclude this with. And a deficiency here, a deficiency there, a deficiency everywhere. That is what is actually the reality. And then now we will see how our panelists will take this message forward. I think there was one question on calcium and magnesium, which you have already answered.
I saw that question and I answered.
Yes, you've already answered. So already, as I said,
I'm still logged on. I'll be sitting here the panel. If there are any more questions, I'll come back.
Sure. Thank you so very much. And as I say once again, we are delighted and privileged to have you as the keynote speaker for this webinar. Thank you, Naren.
Thank you. Thank you.
Yeah. So now as we move ahead with the panel, again, the pleasant task of introducing a galaxy of panelists rests upon one of the key pillars of artists, Dr. Rita Singh, who is an associate consultant at the Divakar Hospital. So Rita, over to you.
So we are now going to have a very interesting panel discussion where Dr. Hema will be moderating the panel, and we have esteemed panelists from different parts of the country to participate in this. So I have the honor of introducing Dr. Hema to you. Dr. Hema actually merits no introduction, but we have to do the formalities. She's the CEO and chairman of the Asian Research and Training Institute for Skill Transfer, has received the FICCI Award for Excellence in Capacity Building. She is the division director of FIGO, Well Women Healthcare at FIGO, and is the president of the Karnataka Association of Healthcare Providers. She is also the state representative of HSSC at Karnataka. Our panelists are Dr. Abha Rani Sinha. She is the principal at SKMC Muzaffarpur and also a professor at the OBGYN department at SKMC Muzaffarpur. She is the vice president-elect for FOXI 2026. She has been the ICOG Governing Council member from 2021 to 2023 and was the president of the Patna OBGYN Society from 2017 to 2018. We have Dr. Girija Wagh, who's also the professor, Department of OBGYN at Bharati Vidyapith Medical College Hospital, and she's a senior consultant at Cloud9 and Apollo Hospitals, Pune. She's a faculty professor, Ogash International Experts General Coordinator, 2016. She was the chairman of the Medical Disorders Committee at FOXI from 2012 to 2016 and vice president, Indian chapter gestosis since 2014. Dr. Amita Pandey is the professor at the Department of Obstetrics and Gynecology at the KG Medical University. She also heads the Department of Medical Education at the KG Medical University, Lucknow. She's a visiting professor at the Weill Cornell Medical Center, New York, and has more than 1,000 research publications in national and international journals and several chapters in various books. Dr. Vidya Thobbi was the president of KASOGA 2023. She's the state advisory PCPNDT board member in Karnataka. She was the chairperson of the Foods, Drugs, and Medico-Surgical Equipment Committee at FOXI from 2018 to 2020 and has received the Mehru Dara Hansotia 2020 Best Committee FOXI Award. She is the ICOG Governing Council member from 2023 to 2025 and has received the FOXI Champion Award at 2019. Now I hand it over to Dr. Hema to take forward the panel.
Such a distinguished array of panelists. We have Dr. Girija Wagh, who's from Pune, but now in Dhule for another program. We have Dr. Vidya Thobbi from Vijaypur, but now in Rajamundry for another program. This is how the knowledge dissemination is happening right across the country. And of course, Abha is from Patna and with a warm clothing station there for this evening, but I don't know what tomorrow holds for her. And of course, Dr. Amita Pandey, one of my very beloved friends and colleagues from the prestigious institute at Lucknow. So when five ladies meet at a coffee table, knowledge cafe, there is a lot that can happen over coffee, as we say, and you will see the lot unfolding in what we actually do in practice. So the tone of the panel will be very, very simple because Naren has laid out a nice, buffet of all the things that could be done. But what are we actually doing? That is the key messages that you will get from our brilliant panelists. So my first question, high-risk pregnancy, every other patient, you will find one of these: anemia, diabetes, hypertension, these conditions. So that means mostly nobody can escape from not seeing the high-risk pregnancy. So all of us are seeing high-risk pregnancies, right? So we agree on that. So yes, these conditions, can they impair nutrient absorption? Can they alter the mechanism of metabolism? Are these demanding increased nutrition with all the plates that Narendra said, just because they're hypertensive, they're diabetic, half of them are anemic? So all of the above or some of the above, or you just say that, okay, everybody's saying dump this, that vitamin. What is the take on this? Yes? No? Abha?
Yes, because I think most of these high-risk pregnancies, they are inflammatory states. They are pro-inflammatory states. So I think the absorption is definitely affected. It alters the metabolism as well as it increases the nutritional requirements. So Amita, my answer is yes.
Amita?
Yes.
Also go with yes?
Absolutely yes. Undoubtedly yes.
Vidya, we recognize that these are the problems. Vidya, you have to unmute, Vidya.
Yeah. I do agree, and I think it is a vicious cycle. There is a inflammation and there is a nutritional deficiency, and again there is a increased nutritional requirements. And of course, yes, for the answer is yes.
Yeah. So, Girija, malnutrition, multiple micronutrient deficiencies, obesity, everything has some kind of a nutritional deficiency. Would you agree on that?
Absolutely.
And it is like almost universally present. So we just take one simple, you're a seemingly simple lady, 32-year-old, second gravida, mid-pregnancy she lands up with gestational hypertension in the previous pregnancy. So she has mild anemia this time also. So one risk factor for the hypertensive disorders is there, and then mild anemia is there. So if we have to presume she has low magnesium and suboptimal vitamin D, how would you recognize that? Girija, is it a routine check to do all this, or should it become a routine? What is your take on this?
See, basically, a simple thing like doing a diet recall would be one very important insight that we can get when we talk, and that has to be a mandate today. Because when we say, are you taking adequate diet? Patient will nod her head and say, yes, she's taking. But when you actually take the diet recalls, so in my experience, I have found that these patients really do not take proper diet. It's like what Dr. Narendra said, that many times they are highly processed foods, or sometimes even in a very good class of society, there is lack of adequate nutrition content. And there are studies which have shown that even in countries like like where there is abundance, like the United States, the recommended daily allowance of every micronutrient is never met with.
So they're eating, but not eating right. Yeah.
Yeah. And they're not getting it also, even if they're eating. Yeah.
So Vidya, Figo nutrition checklist, does it come to your rescue when you have to take a diet?
Definitely yes. Definitely yes. And everybody should follow this nutritional checklist. As Girija told about the diet recall, apart from diet recall, this checklist is very, very useful. Even a simple, this one healthcare worker also can take up, and they can put it which group of food groups the patients are taking their food and all those things. Definitely, it is very useful. Everybody should download this Figo nutritional checklist, and they should follow this.
So busy, Lucknow, OPD. Who takes the dietary recall?
Yeah. So that is where I think I would like to differ from what the other experts are saying, because it is really not practically possible that you are sitting in an OPD with 1,000 women waiting to be seen to take a dietary recall. So
no, checklist if you follow.
Checklist, yes, but dietary recall, no. But yes, at our place, looking for anemia is mandatory. So also getting vitamin D levels is also like very common. And nowadays, in our institutes, many doctors, though it is not there in the guidelines, but yes, we do follow assessment of vitamin D levels. Definitely, I would agree that serum magnesium levels are the neglected thing. Whether it is in the diet or in the measurement or in the assessment, we tend to neglect that. But yes, anemia and vitamin D, hemoglobin and vitamin D levels are assessed to give an idea. In busy OPDs, that is we find that it's the easier way out.
Okay. Thanks, Amita. Lastly, Abhaji. See, Figo nutrition checklist, we've said, if even Manyata, paramedicals are now trained, they will see in 2 minutes and they'll get the data to your table. So you can kind of gauge where the gaps are, because that's also an easy thing to do. And if we make it possible, maybe, somewhere we will move the needle forward. But presuming that anyway 70-80% Baba vitamin D deficiency is anyway there, why increase the cost for the patient and do a vitamin D? More so, serum magnesium is not giving an idea of actual magnesium deficiency at the cellular level. So what do you think should be done as against what you're already doing in your institute?
Routine diet counseling and supplementation.
Abha?
Yes, Dr. Hema. Well, we are not doing routinely vitamin D levels because it's a public hospital and it's not through the government side that we can do it. So but those patients who are at high risk, like in this case, she has a history of gestational hypertension. In such high risk cases, we are going for vitamin D levels, but we are supplementing vitamin D to, I think, all the women. Of course, not in the proper dose. I'm afraid to say that because most of the supplements, they are only containing 400 units. So we are not supplementing in the proper dose. We need to do that. We need to do that. And serum magnesium, yes, that is a neglected thing. Still, we are not looking at it. Those women who are having leg cramps, we are supplementing with magnesium. But I think magnesium we have to look at. And vitamin D also we have to give in proper dosage.
Okay, now one more time to Girija. We have to look at means what? How you look at the vitamin D and magnesium deficiency, because it is too cost intensive, to kind of estimate
No,
the
we have
levels,
to give
etc.
supplements with an increased dosage. I meant to say that.
Sure. No, but I'm just, making it more dramatic, saying that should you actually ever bother to put this in your protocol for check the levels, or will you just presume and start giving the supplements? That's exactly, Abhaji, what I was coming to. Girija, what should...
I would like to give the, supplements in the right pharmaceutical dosages and not giving those 60K sachets and all such things, because sometimes they can cause harm, but a daily supplement of vitamin D would be a good idea, along with micronutrients, for the simple reason that, many times patient resist doing these tests. And like we are working in an NABH accredited hospital, I have to give answers when we recommend these things which are out of guidelines.
Oh,
so we are answerable.
Both Abha, Girija, Vidya and Amita, this sets the stage for us as expert group to think and rethink what actually needs to be done in practice. We recognize that these are deficient. We need to supplement and look at these things in a very different lens. And vitamin D and magnesium, going further, if there can be some point of care, low cost tests available, maybe just to gauge the range. We don't know what the future will bring, but then even for those innovators and the technology guys, we keep on raising these points that we would like actually to ideally, check these, but we don't have a mechanism now. So we don't know what the future brings. But as of now, it's not routine to check this. It's not yet in the recommendation. Should it become a routine is still a question for the future, but we have it somewhere in our radar, magnesium, vitamin D, because we know that only IFA was given with the government before. Iron, folic acid, full stop. Then the calcium came after a lot of fight in that also. Amita also knows it's an inadequate dosage of vitamin D. We have pushed it into that somehow, and somehow we are managing with that. Multiple micronutrient supplementation is the next big bang introduction, which may happen through the government, but ahead of that, in few prestigious medical colleges, we may be doing a study to check whether that's more ideal than the IFA. So that is, to place broadly on a big canvas to our esteemed delegates today, that in the future, these things may also occupy the center stage beyond the iron, beyond the folic acid, beyond the calcium, vitamin D, magnesium, and such micronutrients may come also to be important ingredients to be supplemented to a pregnant woman. Back to Girija again. Gestosis score. We've been thinking and talking a lot about it. Honestly, Girija, tell me how many of the OBGYNs in private practice and in public hospitals, just like a checklist, there is a checklist of gestosis score. How many are actually using it and what value they're finding out of this?
Yeah, now basically how many of them are using it is very difficult and tough for me to answer. But I know of those people who are using them and they are finding it very beneficial, because as Dr. Amita said, that you have thousands of patients sitting in the OPD. You can just have this checklist maybe pasted somewhere on the wall itself, and the attending nurse can just look at it, or an intern can do it for you. Or the patient, like one of my students who is practicing nearby here in Malegaon, he has put a big chart in the waiting room. He says, I ask the patient only to tick and find out half of the things if they don't understand anything. So by and large, we find that the risk factors now in this particular patient also we saw in the history. Historically, she seems to be having 3 gestosis score. So if the score is 3, that means that we have to deep dive into her. It only tells us that this one needs attention. So that is only now. segregated, some publications have come which are trying to, risk stratify based on the score as it goes high. If it's 5 or it's more than 6, what happens? That time only will tell us. But at least that I feel that it acts as a checklist, as we are saying, which makes the patient as well as us aware that now let's tag her as one special patient so that we do not miss on her and give her all these recommendations which are now being, promoted or talked about, that is she having micronutrient deficiency? Does she need anything extra? Yes, sir, we can do.
Right.
Because
Thanks,
some of the
Girija.
score, some of the elements of the score are dynamic ones. Like they wouldn't happen at the outset. They would happen later on. Like you may diagnose her hypothyroidism later on. You may have weight gain occurring later on. You may have uterine artery PI coming later on. So till that time, at least it would act as an, sort of an historical sort of checklist for
Excellent.
us.
Abhaji, my question was, slowly in our thinking process of task shifting, see, everything an OBGYN cannot do. Okay.
Absolutely.
So the task shifting, if as how, when banner or poster pasted, and then, it's like a self-care. Patient checks and tells. Like that, the Google Forms may also be available. Some patients may go in for that. So in your institute, can you think of training the paramedics to do these two simple things, one FIGO checklist and one gestosis checklist? Hoga kya? Ho raha hai kya?
Actually, in our institution, we have residents and postgraduates.
Okay.
So all of them, they are trained about this gestosis score. We have it on our OPD table. And actually, these doctors, they almost remember most of the points of the gestosis score. And they have a mental, I cannot say that every time they tick it on the gestosis score chart, but they have a mental score in their mind. And accordingly, they do the prevention and prediction. They just, taking that into account, they decide about the increased risk of pre-eclampsia.
I just want to add here that
Sure,
there
sure,
is a
Vidya.
gestosis app. As Dr. Hema always talk of femtech. So these apps are very, very useful, and gestosis app has come. So they can download, all the doctors and even paramedical staff.
Especially easily doable on Android.
Easily doable on Android, and they can use it.
Amita, any inputs on the
Yes, I actually
how much
would
the
agree
gestosis
with
score has propelled?
what Dr. Abha just told, because that is what is followed in our institute also.
Great.
Our residents are there, our senior residents, junior residents, interns, and medical students from the learner doctor clerkship.
Super.
They're all there. So, and most of them remember this by heart. The gestosis score as well as the FIGO checklist. So all the high, we have a column where the high risk factors are entered. So if they find anything positive, they just mention it over there. So when the treating clinician is examining the patient and you just see those high-risk factors, you automatically calculate the score. You realize that this is a high-risk patient who has to be tagged and followed.
So this is music to our ears, because the team gestosis score is moving forward slowly and steadily. And if people from the institutions can actually map this, the usage, the feasibility, the user friendliness, and the impact of this, it will be a great data for the rest of the low middle income countries to follow. So brilliant. Now,
I must reiterate here that there are 3 robust, well-validated publications now supporting the gestosis score and its utility. So we can use it with confidence.
Yeah, so more and more people start using it, and the data heats up. And in our very own country, there are different mindsets, there are different contexts, there are different ways the uptake and the further action is done. So lessons learned in an integrated way from all of these experiences will only build up the strength of the gestosis score, if not anything else. And it should become a norm, to include this in one of the routine screening methodologies is where we are heading at. And it's good news for all of us that it is happening in the direction that we expect it to go. Again, to Dr. Abha Rani Sinha. So many things are written here. Magnesium, vitamin B12, vitamin C, iodine, vitamin A, copper, iron. Which one will you take? Which one will you leave? The choice is yours.
Well, I would definitely like to take vitamin A, of course, with a word of caution. Though vitamin A is needed in pregnancy, but it should not be, excess of vitamin A should not be taken. Iron, of course, a big yes. Most of our women, they are iron deficient. Magnesium, yes. B vitamins, yes, they are needed, especially to prevent hyperhomocystinemia. Vitamin C, not very important, but yes, with iron, for increasing the absorption of iron. These days we are having iron tablets with vitamin C. And iodine, if we are taking iodized salt, I think the recommendation of 25 to 50 microgram of iodine is met. So iodine, extra supplementation, we are not giving.
Okay. Amita, just one quick question about iodine. Iodine requirement increases, and in these high-risk pregnancies, we've already agreed upon the fact that some of these requirements increase. So in that, we are presuming probably that they're taking iodized salt, which may still be inadequate. So there are folic acid with iodine preparations available. So would you think that would be a good thing to do to supplement and replace with them?
As long as it is a measured amount of iodine, I think that would be very good, because fortified food and folic acid with iodine combination, these have been there for a very long time, and people have been recommending them. Or otherwise, measuring serum TSH is there in the guidelines also, in the Ministry of Health guidelines. So we follow that, and in those with raised TSH, automatically we supplement.
Sure. Will all the four panelists agree on the fact that there are so many things that we wanted? So slowly we should shift the mindset of the policymakers, that instead of just giving one thing like iron, folic acid, calcium, vitamin D, we want multiple micronutrient supplementation, MMS. Would we all agree on that?
Absolutely. Absolutely.
Super. So then that is good, because, government is still hesitating to get that on. But I think, even in the private practice, if there are the recommended dosage of all these, like a bhel puri, recipe, I call it, if they get the act together and give us the MMS supplements, I think it would be a good way forward. Now, so much is spoken about diet, Vidya, and then food and nutrition is your forte. We normally tell green leafy vegetables, nuts, seeds, avocado, not for the general things like anemia. No. So should we also emphasize and tap a history or two about magnesium deficiency, correlate that and make sure that they take all these? Or how do we normally, because I don't think I've ever said you may be magnesium deficient, so you take spinach. I'll say you're iron deficient. So
yes. I think this magnesium mineral is such an important mineral, but I think it is less studied. Whatever the patients, they come with trivial complaints like nausea, vomiting, or muscle cramps. Usually we treat now the tablets of ultra magnesium, all those things have come, but we just neglect we don't give any dietary advice to them. Actually speaking, whatever dietary advice we give is only we talk of anemia and iron deficiency anemia and other things. We should always put some nice pictures in our consultation room, because as Dr. Amita was telling, 1,000 people, we cannot tell that this is magnesium deficient diet, this is iron deficient diet, and all those things. So whatever we are telling them about diet is all the mixture of all the deficiencies. And as we always face with the multiple micronutrient deficiency. So specifically magnesium deficient diet like that we don't say, but of course, we all know that all green leafy vegetables, we always tell them. And most of the magnesium we are getting from the diet. The 350 to 400 milligram, whatever we consider that is a requirement, most of them we get from the diet. And they say that the avocado, nuts, especially cashews, we cannot tell the poor people to eat cashews, which contains 83 milligram of magnesium, around 28 grams of cashews if they eat. So almonds, various seeds, whole grains, fatty fish and all, that will give you omega-3 as well. And these things we can put the pictures and tell them. We cannot tell the content also. And as we know that the processing of the foods also will have whatever the vitamins, we will lose the vitamins in processing the food. Like spinach, if you cook, the folic acid is lost. Like that. So cooking methods we cannot explain to the patient, and most of the things what we explain is about the diet is very vague. But I must tell that diet is a main, and the nutritional interventions are the mainstay of our whatever the recommendation we tell. Everything we cannot give by tablets also.
Yeah. So you would have found me missing for a few seconds because
Yes.
huge transformer blast in this area, and then
So I just
somehow.
mentioned the magnesium rich diet. I just went through, and this black beans, lentils, chickpeas, and soya beans, and the tofu. They say that is tofu is a processed soya milk. This one that has
About groundnuts,
even
groundnuts.
groundnuts, and these are the very rich source. And avocado, they say, and banana, the simple banana, which is rich in magnesium as well as the other ingredients, potassium and all. So banana is also antidepressant. So ask your patient to eat banana. And these things are simple because even the rural areas, we should consider the social factors, whatever the availability at their local things. All these matter whenever we are talking of the nutritional and diet. That's what I is a say.
Sure, because
Yeah.
nutrition and the way we counsel and all has changed a
Yeah,
lot, because
yeah,
we are
yeah.
now slowly getting it to the center stage, Vidya, thanks
Yeah,
to so much efforts being taken locally, nationally, globally,
yeah, yeah.
etc. So we are just making big noise about it, so it's, I think, escalating. So anywhere making our voices heard is a right thing to do, because we traditionally believe that diet counseling, etc., is not our forte. So it's like, it's whose job is it anyway? Because apart from some tertiary hospitals who have the luxury,
Yeah,
the
dietitians.
responsibility lies on the OBGYN and the paramedicals in smaller settings. Now, major, bigger, serious uses for magnesium sulfate. Amita.
Yes, so as you have put wonderfully in this on this slide, Dr. Hema, these are the three accepted, recommended, endorsed uses of magnesium sulfate. We know that magnesium sulfate is the gold standard, the drug for prevention as well as treatment of eclampsia and severe preeclampsia. So we give it to these women, and we know that the mechanism of action is also well known to all of us. We know that it raises magnesium raises the Caesar threshold, being a calcium channel blocker. So, and there is another, I was reading, there is another mode of action. It acts on the N-methyl D-aspartate receptor, and it leads to membrane stabilization. So that is why it works wonderfully for prophylaxis as well as a therapeutic use in eclampsia. Moreover, it decreases the acetylcholine transmission. It promotes vasodilatation of the cerebral vessels. So it decreases significantly the adverse effects of eclampsia. Like we see that the patient is knocked off for quite some time. So all that is decreased. It prevents the disruption of the blood-brain barrier. So it has multiple uses. The second use in preterm labor. Yes, here definitely magnesium has not become so important, and we still rely more on nifedipine and other calcium channel blockers. But yes, it does have a role to play. And then finally, neuroprotection. That is also a very important place where magnesium plays a very important role. And we all know that it is there in the recommendations. All recommendations have it on their list that
Right.
any baby delivered before 32 weeks, yes, some guidelines also recommend before 34 weeks that we have to give neuroprotection using magnesium sulfate. But yes, we need to keep it in mind that it has to be given just before delivery is anticipated, for the same reason as it is given for preeclampsia. It stabilizes the membrane, and hence it provides neuroprotection. It prevents the baby from being adversely affected by HIEs, and it actually helps in the long-term outcome. It improves the long-term outcome of the babies.
Wonderful.
So these are the three very, very important and recommended uses of magnesium sulfate.
Wonderful. Now, thank you, Amita. We are back to Girija. She did a wonderful conference in the capacity of the vice president recently on zero tolerance to premature labor. So, Girija, was there anything new discussed on slowing or stopping premature labor, the use of magnesium sulfate and beyond? Any newer thoughts on this? Or those who are magnesium deficient are more prone to premature labor? So better pay attention to this in a preventionary manner, plug them with magnesium. Is there any thought process like that?
See, magnesium sulfate as a tocolysis is a very effective medication. Unfortunately, it sort of keeps on swinging from here to there because the ACOG recommends it more and practices more, while the RCOG talks about etosiban and all these things. So therefore, we as Indians are always confused. We don't know. But I love it. For the last 2 decades, I've been using magnesium sulfate as a tocolysis, and it's wonderful. And that was reiterated in our conference as well. And it awards a neuroprotection action. And as Dr. Amita said, that stabilization effect has been found to be very profoundly anti-inflammatory, both for the brain of the baby as well as the mother. And that is one thing, therefore, using it, very proactively and in the right dose, without fear. Without fear is very important. Because some of my students, when they have left the institution and gone out, they have been reprimanded for using magnesium sulfate while they were ye kyun use kiya, isme ye hota hai, respiratory damage and all that. It's not like that. Only thing is, what I have observed, Dr. Hema, is that once you have put a patient on magnesium sulfate, and if now for some reason you are going to deliver the baby, you understand, like, she has high-risk mother, you're planning a C-section. I feel that we should give a wash off for at least 1 hour. So 1 hour prior to the actual birth of the baby, just put off the magnesium sulfate. And that helps because otherwise the babies come out well. But they forget to cry. They're looking at you. All the parameters are fine. But somehow they cry and respiration is not. This is my observation. My Dr. Girija Wagh jugaad, you can call it. But
yeah, it's sometimes, we have the jugaad mindset. So we keep observing, keep documenting, and keep it. Finally, one day it may reach into something that everybody should do. And such wise tricks and tips, as we call, are most welcome. Now, on the same
I want to add.
Yeah,
Here, I just want to add, if I may, Dr. Hema, that we have also seen that when we administer magnesium sulfate to the woman, we need to inform the anesthesia team also, because at times they do face problems if by chance the patient has to be given a general anesthetic. So that is another place where we need this washout period.
Sure.
And if not, we need to inform the team so that they are ready with their antidote. Calcium and all they administer.
Excellent. The points very well taken. On the same issue, I want to quiz both Abhaji and Vidya. Vidya, in your experience as an assessor for Manyata, how confident the staff nurses are to give the magnesium sulfate to a severe preeclampsia?
Yeah. I must admit that this Manyata training is a wonderful training. And so many, I got the feedback of these Manyata trained institutes. And recently we did in our Karnataka State Conference also. We did in survey as well. In these Manyata trained, whatever centers are there, they're very, very confident because we teach them what is the exact dose, how to give, and what are the complications, and how to monitor this patient. So they have saved many lives, and they have documented also. They have sent us videos, and I must congratulate the trainers as well as the people there. So, and consequently, the staff sister who are trained, they have trained further. Whosoever new are joining that institute. So that is the success story of Manyata.
Excellent, because Vidya, if you remember in one of our, about 12 to 14 years back in one of our Karnataka state conferences, there was so much controversial discussion about the magnesium sulfate. The whole audience got so kind of flustered and confused, and they were tearing their hair. To give or not to give, what will happen? There was a whole sea of unnecessary panic.
And I must say that now that IV mag has come, no, that they need not load it now, but that has to be again trained because they should not give that that infusion very fast.
So from a
And that
decade
will-
now, we have
a
really
decade now,
changed the
yeah.
mindset and made the people competent and confident. Girija wanted to say something
Yeah,
before
I
we go to
wanted
Abha?
to say two things about this. One is the anesthesiologists find magnesium sulfate very
They
benefiting.
benefit.
Fact, because it has a wonderful analgesic effect and a vasodilator effect. The second thing is it's a part of training, Dr. Hema, because I was probably the first batch of junior residents who started using magnesium sulfate confidently. Now, at the end of 32 years, when I become the professor, now my generation people will now train, more confidently.
Yeah.
And there was that dual thinking whether it's safe or not. That's
Yes.
one. Second thing. And the third most important thing is I don't like to speak anything negative about magnesium sulfate ever because, antidote, I always say, don't speak of magnesium sulfate toxicity. You can just say an untoward reaction or something. But because then, the acceptability of such a wonderful drug should not go.
Absolutely. That's exactly what I was referring to, when it happened in that conference, where everybody had their own share of thoughts, and then, it was more chaotic than a consensus. So I think we've come a long way from there, and slowly, steadily,
Because
we're consolidating.
between my internship of the Lytic cocktail and my JR1-ship, I saw women living and not dying because of eclampsia.
Yeah.
So that was
Excellent.
a huge appreciation that we had.
Excellent. Yeah. Now, Abhaji, for you.
Yeah, I too agree with both Girija and Vidya that Maxulf is a real success story, we can say. We have also used Lytic cocktail, and now Maxulf, I think after 90s, we have started using Maxulf. And this Manyata training, it has done wonders. It has sensitized, I think, all the centers where the paramedics were trained. They now know precisely what is the dose, how to administer, what to look for, what are the signs they have to see. So this training has done wonders, and I think now it is universally used. There's no other anticonvulsant which is being used for preeclampsia, and also for prevention of seizures also they have been trained. So I think this training has done a wonderful job.
Excellent. Abhaji, the question to you, what I wanted to follow up was, say for seizures, eclampsia, severe preeclampsia, they use. In your institute, how much more the usage has gone towards the other two indications, like stopping labor?
Yeah,
is that sensitization on these two indications also quite in the front?
Preterm labor, no. Preterm labor still, we are not using much of Maxulf. But yes, for neuroprotection, 100%. Any delivery where we expect a delivery within 24 hours before 32 weeks, we are giving Maxulf, and the dose is the same as we all know. It has to be continued up to delivery or up to 24 hours if the woman hasn't delivered. So all our PGs and residents, they are trained in this, that they have to use Maxulf either for prevention of preeclampsia or treatment of eclampsia, and also for prevention, for neuroprotection. I think that is universal.
Excellent. Yeah, I think these are very, very important points conveyed. As Amita said, that slide gave a very clear three-pronged direction towards why the magnesium sulfate needs to be used. So again, back to one more confusing, tough question on the fetal programming and magnesium. See, if we think it is so important, then we have to be giving it equal importance as the proper in utero environment, which we talk about so much. So, Girija, this question is to you. According to the reported data, low magnesium, maternal magnesium during gestation should be included in the multiple factors as the basis of fetal programming. So, long-term impact of magnesium. Have we ever, because you're a great one for gathering the data, thinking ahead, because long-term follow-up, we may not really have and recognize that magnesium deficiency may have caused this. So what are your thoughts on this issue of importance of magnesium for this reason?
One simple, very low-hanging fruit to catch here is magnesium is definitely important for the musculoskeletal development of the babies. And that is, alongside calcium and vitamin D. This has been proved beyond doubt, and this is very important. Secondly, it would have an indirect effect in trying to prevent preeclampsia in the mother, and therefore its resultant abnormalities, which would happen because of placental insufficiency. And thirdly, it is also known to improvise the future outcomes, because if it is found to be deficient, then there is definitely growth related issues that can come. Now, these are very vague terminologies you may think, but there is definitely some sort of a gene upregulation which may happen, which may have lasting effect. For the baby having long-term issues, just a few weeks back, we had a young girl. Now, madam, we have heard of boys, but a 27-year-old having a heart attack and getting into a cardiac ICU.
Yeah.
So there is some sort of a programming which gets probably then further escalated by the environment and their lifestyle changes. But the programming happens somewhere in the uterus. And this therefore requires cognizance, because when we are trying to prove, and today I think all these years we have struggled in trying to prove what we have always believed. Today, with the advances in microarrays and assays and so many things, I think this will be quickly proved now that yes, they do cause problems. They may cause weakness of the heart. They may cause weakness of the vessels that are forming. And these would later on give rise to such kind of a problemation, and which would be even transgenerational.
Yes.
Like, in my life, first time, it was Dr. Hema who opened my eyes to hyperglycemia being transgenerational. And I have been so diligent. So, Amita, you must have said कि तू diet recall कैसे करती है? मैं घर भेजती हूँ patient को बोलती हूँ, you go home, get 3 days diet recall and come back when you come for the NT and double marker test report. We'll analyze your diet. That is how we go about it. But that has, got into my brain so much that finally it's not about the woman now, the baby now. It is also after for both of them, and later on for the future generations. So we
Yeah,
have to be
because,
very...
Girija, the title that we gave, GDM today, NCD tomorrow.
Yes.
Arey lag gaya. For 2 generations, that's a karma translates into the generation next also. So it's quite a thing. So, Amita, do you find, see, so much we are campaigning for magnesium sulfate usage, and mostly they're all, my master champions here are vouching for the fact that yes, they monitor, they give the correct dosage, etc. Do you find many instances, like many fear that it will become excess dosage, or it's really not an issue?
See, practically at our place, every day we get at least 3-4 patients of eclampsia. The number increases during the winter months. Severe preeclampsia, we get many all the year round. So considering the total number of women who are given magnesium sulfate, I would put it as around 5 to 7% do exhibit either absence of deep tendon jerks or respiratory depression. Fewer show respiratory depression. More commonly, we see absence of deep tendon jerks, wherein we do stop magnesium sulfate, but as per the recommendations, after a wash-off time of a few hours, we do restart it. It is only where the respiratory rate is depressed, where we think of giving calcium gluconate to the woman, along with some support for the respiration. But yes, I would agree with you, the percentage is very, very less.
Excellent.
As far as the women who go into respiratory depression is concerned. What is one very important thing that we have realized is we do give the loading dose of Maxilf the moment the patient comes, but we also send all the investigations, the whole PE profile, including serum creatinine. And these days we have become careful that if the serum creatinine is more than 1.1, we usually avoid giving the maintenance dose. And believe me, many women do not need maintenance dose. The loading dose works excellently, or even if she has got 3 or 4 maintenance doses, that is wonderful.
Excellent.
I think we not give it for hours.
So very practical and then properly conveyed. I'm so delighted with the messages that are going out to the audience. However, audience have put an array of questions which I would like to rapidly take up after the next 2 slides. Abhaji, this question is again for you. See, so many countries, are not at all wanting to, like I say, all countries recommend folic acid. We all know that.
Yes,
but only half the countries are recommending iron because others think that they are sorted and they don't have iron deficiency. 1/4 only are telling about vitamin D. 1/4 of the countries are saying, okay, start paying attention to iron. But nobody has said anything about magnesium. So what should we be saying, Abha?
No. Whatever discussion we are having today and what whatever literature is there, I think we should recommend, because we are a different type of country. We are low middle class country, LMC. And here, I think most of our women, they are deficient in vitamin D. So if we are thinking of giving preconceptional, I think it should be a perfect combination of iron, folic acid, along with vitamin D and magnesium. I think that should be the message today.
Excellent.
And
excellent. So, we do recognize that this is playing an important role for a variety of things, because, the magnesium inclusion, trying to really reduce the preeclampsia, delayed growth, gestational diabetes, etc., was not so much coming in the forefront. We were bothered about many other things like folic acid for neural tube defects and iron for anemia, etc. But magnesium was not somehow, occupying any kind of stage, leave alone the center stage. So this is what it is. Again, now, very quick question to all, starting from Vidya Thobbi. Dosage, how much you'll give? Vitamin D, okay, now we are agreeing that, even if you don't study the levels, it's fine, because Narendra also said burqa and then not going out in the sunlight and all, we are not getting. So 80% of vitamin D deficient. But dose, what you'll give?
About what? Vitamin D?
In pregnancy.
In pregnancy.
In pregnancy also good if you start. But
most of 80% of our Indian women are
deficient.
vitamin D deficient. So whatever the calcium supplements we are getting, they have vitamin D3 in that.
So will you calculate like this? Now you said Hema is talking about technology. Now there's one silly app.
Yeah. There are so many apps. I just went through the apps. There are multiple apps. So those are really, I don't know how much they are regulated, these apps. No, we don't know about the app regulator again.
Okay.
It's a vitamin D calculator and regulator, but how this app should be regulated by FDAs, I don't know. But there are vitamin D calculators, they are available. And really how much vitamin D you require, because we are not doing every patient, we are not doing vitamin D levels. So ideally, whatever with calcium, we are getting vitamin D3, that is around 200 to 400. But now there are WHO recommendations, that WHO says that there is no need to supplement as such for prevention of preeclampsia and all. There are many studies and many RCTs. The recommendations were 2012. Again, they have defined and redefined in 2016 again. So though we know, everybody knows that vitamin D has got its own role in calcium absorption, bone metabolism and all those things. The recommendations are around 200 to 400. Now, whatever 2000 RCOG, ACOG, their recommendations are there, they are only in high-risk pregnancies.
See, as it is, Manita Rahuja is asking, should you add calcium with magnesium?
1000 milligram, as they say. But again, there are no recommendations from FOXY or WHO.
So, Amita, what dosage you will battle for? Vitamin D, if you want to give.
Hema ma'am,
give now properly.
Yes. So here I will like to tell you that we have conducted several studies on supplementation of vitamin D in pregnant women. And we also agree that at least 1,000 international units per day should be there. So the basic dictum that we usually follow in our institute is 2 sachets of 60,000 international unit in the second trimester and 2 sachets of 60,000 international unit in the third trimester. So that would be 1,20,000, 1,20,000. That would cover 8 months, and that would be sufficient. And that would actually help in calcium absorption, because in our study, madam, we followed the babies also. We followed the babies and we did the anthropometry of the babies also. And we followed the babies till 18 months. And we realized that the anthropometry of the babies also lags behind if we don't give vitamin D to the
and even vitamin D drops are given by pediatricians.
Yes. So that is why if we give 2 sachets and 2 sachets, it will not lead to any toxicity.
Sure.
It would be safe. It would in fact help in calcium absorption, because at least in a public hospital like ours, I would say 95% of our women are deficient.
Correct. So it is worthwhile, and then your dosage scheduling also is practical and feasible. It makes sure that it goes. Abhaji, if you are given the choice, calcium and vitamin D, many combinations are available. No? Like suppose Supracal 2000 IUs of calcium, vitamin D is added to the calcium. Instead of giving separate, just give this every day because anyway they are deficient? Would you agree with that? Or it is like, it's a bit too much?
I think if it is available in a single tablet, I think the compliance will be better, whatever preparation is there. But as Amita has suggested, for our patients whose compliance is poor, I think giving 2 sachets in the second trimester and 2 sachets in a third trimester, I think that is a brilliant idea.
Yeah.
I think we should also need to follow it. And I also learned something from Amita.
Yeah.
So I think that is a brilliant idea. But otherwise, we are giving the dose is really underdose what is coming in the regular prenatal vitamins because they are all 400 international units. So we have to supplement it separately with this. So the patient will go on taking 2-3 tablets a day, and then again the compliance will become poor.
Girija, your take on this. Suppose a calcium preparation with 1,000-2,000 IU is available. Will you prefer to give that? Because anyway, in one dosing, she's, you are sure in your mind that adequacy is there.
See, basically, if I get an opportunity of proving a deficiency, then I would follow what Amita madam has said, that I would give them the high dose. The problem and the challenges out there is the endocrinologists in our city are extremely against giving 60K of vitamin D in such high dosages. But on the other side, Dr. Hema, if you look at the recurrent pregnancy guidelines, which are now come up, the new ones, they are saying that vitamin D is one of the reasons why RPLs would occur. So we are in a quandary. So I don't have any confidence to answer this question. If I can learn anything from this panel, I'll be really happy.
Yes. I too.
Yeah, please.
Yeah.
No. Because see, the vitamin D overdosage is seldom occurring because, Dr. Horlicks and everybody came and spoke about it. They said, don't worry, you can give. So if you're giving 60K in the sachets that Amita mentioned, that's one practical way of doing. Some calcium with a good dosage of vitamin D are available. So if you give it as a combined tablet and daily the patient is taking, so that may also be, daily taking is also going to improve the compliance only because calcium to jana hai. So with that, this will anyway come. So Suhasini Inamdar specially has asked, pregnancy, which dose regime is best for vitamin D? Daily or weekly, oral or injectable? Who is going to battle for injectable now in this panel?
No.
Endocrinologists say give injectable, oral is useless. That's what they say, that, if it's oral is not working, give injectable. Daily
How many
have
of
a
you think
better.
it's useless? Do you think do we think it's useless? I don't think so. It is useful. Okay. Either you give it on weekly basis with sachets, that's fine. You give it on
once in a month, that's also fine.
Yeah. So
they
give
say
adequate dosage. 200, 400, not sufficient. Injectable, not required. Daily or weekly is your choice based on your patient compliance. So calcium and vitamin D, we are sorted. Iron, folic acid, we are sorted. But magnesium, as of now, in a standard combination, it is not available. So there are some preparations of magnesium and vitamin D.
Vitamin D, yes.
Okay, so suppose you're giving a calcium with a 400 vitamin D, then maybe you'll give a magnesium and vitamin D as an additional one more tablet so that magnesium bhi jayega and calcium also, the vitamin D3 also goes. So maybe we have to, as how we have given here, individualized, personalized, baseline nutrition status, comorbidities, dietary habits, gestational age, everything you put together, and then you say little of this is definitely needed for this patient. So magnesium, I don't want to omit from this patient. So I will give a magnesium vitamin D in an adequate dose. I will anyhow give her the calcium. Maybe inadvertently with little less dose also it may. That is also fine. But folic acid is no doubt. MMS, multiple micronutrient supplement, if it comes to stay, then maybe it is a blanket answer for many of these things that we are discussing, but I think it will still take time. So, Shobha Lande says, I usually ask all anemic pregnant women to take a glass of Nimbu Sharbat every day. Good thing to do?
Yes.
Very nice idea, but some of the patients are so finicky that मुझे lemon से सर्दी होता है, फिर क्या करूं?
जिसको सर्दी नहीं होता है वो तो ले लो. So because vitamin C and iron absorption, that is more than. Maninders, as usual, the question, calcium, magnesium should be added in all the prescriptions. What should we be advising? Testing magnesium serum level is not practical. Yes, that we agree. It's not practical to test, but we know that it's important. Yeah. Boliye, Girija?
Can I leave? Because people are waiting for my lecture now.
So I think there are just another 3-4 questions which I'll ask the other panelists to answer. But we really, really appreciate Girija. From wherever you are, whenever asked, you always add value to the panels that we do. So thank you very much. And may the forward progression of your knowledge dissemination help many more mothers and families. Thank you so much, Girija.
Thanks for the opportunity, dear. Thanks.
Thank you. Well done.
Yeah. Bye-bye, everybody. Bye.
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 So again, there is a question from Suhasini Namdar. Magnesium sulfate need to be stopped to prevent PPH due to atonicity that it may cause. Amita?
Yes, there are many studies now which have shown, RCTs are also there, where it has been conclusively proven that administration of magnesium does not lead to PPH.
Excellent. Anyway, that 1 hour washout for a different purpose, what we have said, so that stays, but you don't have to be apprehensive about PPH. Meenakshi Shukla asks, magnesium supplements beneficial in antenatal patients with history of epilepsy.
If we go by the mode of action of magnesium, I think it should help, because the ultimate mode of action is stabilization of the membrane and blockage of the calcium channels. So it would eventually help in epileptics also, because that is the mode of action by which pathophysiology by which epileptics have fits.
And again, there is a question. Abhaji, do you also respond in the same way as Amita has said? Because Naina Kumari Kadamba has asked, with magnesium sulfate, should we watch out for PPH? You always watch out for PPH in any case.
Yeah.
Even in our experience, whatever RCTs and studies are there, apart from that, even in our so many years of practice, we haven't seen PPH in epileptic patients because of MaxSul. We haven't seen. So our clinical experience also says that PPH is not prevalent with use of MaxSul.
No, in all the patients, we are doing active management of 3rd stage of labor, and we are very much vigilant in all these preeclampsia patients, because minimal blood loss also can lead to PPH.
Sure.
So definitely, magnesium sulfate as such will not cause any poor.
Many of these eclamptic patients are anemic, and we know that it's a deadly combination. Anemia with preeclampsia definitely leads to PPH. But MaxSul as such does not cause PPH. I think that is my take.
Absolutely. Great. I think the voice is quite uniform about this, because for whatever magnesium sulfate your indication you're giving, it's so worthwhile that you don't unnecessarily have the fear of PPH, because as the vigilance in an overall way for PPH, anyway, you should be doing, but this will not precipitate. There is a question about oral magnesium sulfate or IV. Which one we should be using?
This is for what? Oral magnesium sulfate.
Depending on the indication. If it is for prevention of preeclampsia, definitely we are using IV. But if it is for supplementation, like in the preconceptional phase or in pregnancy as a supplementation for muscle cramps, I think oral will do.
Agreed. Yeah.
And but that salt is not magnesium sulfate, right?
Right.
No, not sulfate. Citrate. Madam said citrate.
That's right.
Citrate.
And Pratibha Garg has asked, Madam, please tell about the protocol of magnesium sulfate to prevent preterm labor. Amita.
So preterm labor, all the Zuspan regime in which we give the loading dose of 4%, the same thing we follow for neuroprotection and as well for prevention of preterm labor, which is 4 gram IV, very slowly diluted over 20 minutes, followed by 1 gram per hour by infusion, maximum for 24 hours, by which time sufficient tocolysis would be there. You just want to buy time to give antenatal steroids.
Excellent. And Neha Agarwal is asking, what about D3, 60K nano shots? Many companies are coming with shots, meaning I don't know whether Neha means injectable.
Shots means injectable.
So
that we answered.
We just said that maybe endocrinologists will go for it, but we are happy to give the oral. One anonymous attendee, what about adequate dose of magnesium to be given? So that is the consensus that we are hoping to draw from, open discussions like these, because some of them have brought to our notice that it is important. That is undoubted. The key roles which it plays in certain indications which we are already doing, that's also undebatable. Certain concerns about toxicity and increased ppH, they have been dispelled. Lastly, it is good to give oral supplementation in combination with calcium, which may be available in future in the preparations that we do. As how we are paying attention to folic acid, iron, calcium, vitamin D, magnesium also seems to be now on par with the positioning that it is getting for a multiple variety of things, inclusive of the prevention of high-risk pregnancy and other advantages that it has. So slowly and steadily, this panel has brought us further in the track about our thinking on magnesium, vitamin D, and more to enhance the optimal outcome of especially high-risk pregnancy. And we know that all of us as OBGYNs are dealing with millions of high-risk pregnancies day in and day out. Short-term, medium-term, long-term advantages we have already seen. And the way forward for defining the exact dosage, for actually making it a compulsory ingredient in the preconception, for making sure that throughout pregnancy she gets adequacy of dosages and the future generation is also protected on lot many things. These are absolutely wonderful points which have been in such a simple and such a practical manner and honestly put forth by our panelists today. And on behalf of team artists, I would like Sheetal Joshi to thank each and every one of you, in addition to my heartfelt thanks to the backend team at Pharmed, which has Jayanta, Arvind, and Jigar, and the rest of the team who have been relentlessly working to bring Knowledge Cafe, a delightful coffee session in the middle of the night once every month, and we are learning more and more. And of course, our very own team, who would now be happy to thank our brilliant panelists, Girija, who has just left, but Vidya, Amita, Abha, thank you ever so much. For a formal thanks, Sheetal, and don't forget to thank our own backend artist team, Rita, Puni, Divya, Pallavi,
Yes.
in addition to yourself.
Yes, ma'am. Yes, ma'am. Yeah. Yes, on behalf of Dr. Hema Divakar and team artists, I would like to extend my sincere thanks to Dr. Narendra Malhotra for his valuable insights, and to our esteemed panelists, Dr. Amita Pandey, Dr. Abha Rani Sinha, Dr. Girija Wagh, and Dr. Vidya Thobbi for their excellent contributions. We appreciate and thank the support from the Pharmed team for their seamless coordination and for their support. A big thank you to our team artists, Dr. G.V. Divakar, Rita Singh, ma'am, Dr. Purni Narayanan, Divya, and Pallavi for their continuous support and coordination, which is very important to us. And thank you to all our delegates for joining us today. A special thank you to Dr. Hema Divakar for every time bringing with such interesting topic and excellent experts pan-India, not even pan-India, globally, I can say. So thanks a lot, ma'am, for making it so interesting. And finally,
Thank you, Sheetal, with the permission of the panelists.
Yes.
Sheetal, you will say your final sentence after I just pause for a minute. If the panelists do agree, there are some 2-3 burning questions here. From
Yes.
what stage of pregnancy can we start magnesium? Vidya Thobbi.
Second trimester.
Would Abha say preconceptional?
Preconceptionally, madam, because the embryonic
Magnesium.
health is also important. So I think at the time of organogenesis, if some magnesium is inside, with as it regulates the immune function also. So my take is for preconceptional.
Amita?
I would agree, but I just want to ask one question myself. There are a few, I read a couple of studies where they said that calcium and magnesium should not be taken together because perhaps the absorption channels are the same. So they should be taken at different times. So perhaps we should route for separate administration, as we say that iron and calcium should not be taken together. Similarly, we have to say for calcium and magnesium that it should not be taken together. I don't know. I'm not very clear about this. So this is a question that I pose to the panel.
There are so many. I just want to add here, there are so many gray areas. And this second trimester also I have taken from some of the studies. Maybe I will share with Dr. Hema. And they say that folic acid definitely yes in the preconceptional area. But we intervene. But this they say that magnesium should be supplemented second trimester and onwards.
Slowly
Okay,
we are
here I
looking
would
at
like
it
to add one
differently.
thing. Because magnesium is nowadays being strongly recommended by our psychiatrist colleagues for inducing sleep.
Yes.
These women with
Yes, yes.
anxiety
Sleep
and
disturbances is a
who have
big
insomnia.
issue.
So they say that in the first trimester, if the woman is having insomnia, you should give her magnesium to induce sleep. So considering that in mind, keeping that in mind, I think we can give magnesium safely in the first trimester for other indications also.
So,
Again
Abha for
open to discussion.
preconceptional, Amita for first trimester, Vidya as on today for second trimester, but it's a continuum of thought processes that we are pitching in today's discussion, which will evolve. And the fact about the companies bringing out magnesium and vitamin
Calcium.
D as one combination, calcium and vitamin D3 as another combination. That is also what I have noticed. So maybe I should check with the pharmacokinetics, pharmacodynamics to see whether what can be combined with what. But in isolation, we agree that each of one of these is really important. Again, Amita, you're for great one for the dosages. So premature labor dosage you told, now neuroprotective dosage of magnesium sulfate.
It's the same. That is the wonderful thing about it. It's the same. It is 4 gram IV loading dose. You have that 50% solution is available in 2 ml vials. So you take 4 vials in 120 ml syringe, dilute it with 12 ml of normal saline, give it slowly over 20 minutes, followed by through the infusion pump 1 gram per hour. That is for neuroprotection. You give it minimum 4 hours before delivery is anticipated. And there are studies which say that you continue till delivery. There are studies that say that you wait for a wash-off period of some time.
Excellent. I think it was re-emphasized and re-clarified. Tejavati Venkatesh says this was a wonderful session. So we are happy about that, patting our own backs for that. We've seem to have done a good job. So the iodine, the magnesium, all these things which are, emerging as important issues, we are discussing one behind the other because these are less harm, so much benefit, available and doable, givable. So we want to just focus on a few simple issues like these, which everybody can do. That's the main idea of discussions like this. We don't want anything which is very niche and very, hard on our minds, whether to take this or not take this. Whereas these is easy to recognize how we move forward. So the Knowledge Cafe is really, stimulated our thought process for sure, which we will put it into a concretized action and thereafter through the recommendations as well. Sheetal, one last sentence.
Yes, finally, because I had almost thanked everyone, and really I appreciate the delegates who are over here asking so many interesting questions, and the panelists are excellent, and so much of research work has been done. I'm so happy that it has been reaching not only the gynecologist as such, but all other people would be really beneficiated with this particular session, and lots of viewers would be there. Thanks a lot, everyone, finally. And Sheetal Joshi today will sign off from Team Artist for an excellent session. Next time we are going to come up with much more interesting topic. We are finished with iodine, magnesium, vitamin D, and there is still more. Thank you, ma'am.
Thank you so much.
Before you sign off, I think on behalf of all the panelists, I would like to thank Dr. Hema Divakar from the core of my heart. Thank you so much for giving us this opportunity. We really enjoyed being with you. Thank you so much.
Thank you.
Thank you, Hema. So it would be always brainstorming sessions with Hema. Yes. Thank you.
Thank you so much.
Thank you, everyone.
Everybody. Thank you.
Thank you, Rita. Thank you.
Thank you.
Bye.
Thank you, Rita.
Bye.
Thank you, Sheetal.
Thank you.
Thank you, Pharmed.
Thank you. Thank you to the entire team. Thank you so much.
Thank you, Amita. Thank you, Abha. Everybody.
Thank you, Dr.